Alright, diagnostic testings. We're talking about GI. So the barium swallow is going to be a test that we look at the upper GI series. It can identify structural abnormalities, hiatal hernias, gastric ulcers, tumors, peptic ulcers, gastric disorders. There is a video here which you need to watch. And anytime you're in clinicals, if someone is ever doing a test, your patient's doing a test, always take the opportunity to go and watch that. You can learn a lot from that. The barium enema is going to be the lower GI series, and so it can identify polyps, inflammation, tumor strictures, varices, and an inguinal hernia. And again, here's another video. With the lower GI series, this barium enema, they are actually going to inject about 1,000 to 1,500 mils of barium into the rectum, and then they're going to make that patient hold that for about 30 minutes. And so that can be very difficult. You can encourage the patient that they probably do feel like they need to go ahead and evacuate that out, poop, whatever. But they need to hold on to it as long as they can so you can complete the whole test. A lot of times it will cause cramping, and so just let them know, kind of hold on to it as long as you can. As long as that barium is still in the bowel, they will have white stool. So also watch for that and let them know that we need to clear out that barium. And so we encourage a lot of water and fluids after that. Nursing considerations, you want a low residual diet the day before. So low residual diet is going to be things like low in fiber, not very many fruits or veggies or whole grain wheats, nuts, anything like that. We kind of want to cut that out the day before. And then about 8 to 12 hours prior to the test, they're going to actually be NPO. Barium is constipating, so we want to make sure that they do get plenty of fluids after that test. The cholecystography is going to be a gallbladder series, and you actually don't see as many of these tests as we used to. And the reason behind that is just the fact that we can do an ultrasound, which is so much easier, and it's usually always 95% accurate. Really easy. If for some reason the ultrasound doesn't show what we need it to, it's not completely conclusive, then that's when we kind of do the cholecystography. And so what this is it's a gallbladder series. It's an oral ingestion of iodine. So of course our first question to our patients does need to be if they have an allergy to iodine. We need to check that out. Allergy to shellfish, anything like that. If they do, of course we're not going to be doing this test because the tablets that they take the night before the procedure contains iodine, and this test can actually identify stones in the gallbladder or the common bile duct area and tumors or any other obstructions. With these tablets, they will be taken at the night before, and we want to encourage at least 250 mils or more of water with it. They're also going to eat a fat-free meal the night before, kind of not high in fat. We don't want to stimulate that gallbladder. And then after the test, that's when we actually encourage a higher fat meal so that it will go ahead and wash out and kind of clear out that iodine. So that's that test. The cholanginography is another test that we can sometimes do. It's going to determine the actual patency of the ducts from the liver and the gallbladder. There are 4 different types, but the main one we want to know is this ERCP, endoscopic retrograde cholanginography pancreatography. It's dye injected into common bile duct and the pancreatic duct through an endoscopic tube, and then they're actually able to visualize that with radiography. Radionuclide imaging, this is going to detect actual lesions of the liver and the pancreas. It's going to assist in evaluating any kind of gastric emptying. It will show you the actual size of the organ, and it's done under imaging scanning with radioactive dye. With this one, it is contraceptive and pregnant ladies, so if they're pregnant, we will not do this scan. And if they're breastfeeding, we would encourage them to go ahead and pump and dump so none of that radioactive material gets to the baby. Computed tomography, a CT scan, I'm sure you guys are all familiar with this. You've probably seen those in clinicals. This is going to show the actual structures that may not be seen otherwise. Usually we'll give IV or oral contrast prior to the test, and then they need to be NPO for about 6 to 8 hours prior to the test. This test is relatively easy and really quick, so it's kind of our go-to. If for some reason the CT is inconclusive, we don't see everything that we need to see, or we think we've missed something, we'll send them for an MRI. And MRI is magnetic waves are used instead of radiography to visualize those structures. So a lot of times we just get a better picture of the tissues that are there. Usually contrast will be used and the client is going to be NPO for 6 to 8 hours prior to this test. Like I said, ultrasonography, we use this quite frequently. It's high-frequency sound waves. They're directed through the body. They bounce off structures and they show the size and locations of the organs. A lot of times this is going to help us pick up, detect any kind of inflammation of the gallbladder, or if there's even gallstones there. It can show us pyloric stenosis, where the opening at the bottom of the stomach is just tight. So ultrasound is really great. It's usually 95% accurate and it's really easy to do. So that's kind of first line. Percutaneous liver biopsy. For this one, we are actually getting a small amount, just a sliver of the liver tissue, and it's being obtained by placing a needle through the lateral abdomen wall directly into the liver. So the client has to have coagulation studies done prior to this test, a PT, an INR, a PTT. Your major complication with this is going to be bleeding. So find that in your book, highlight it, star it. That's really important. With a percutaneous liver biopsy, the main complication is going to be bleeding. So know that. With the liver biopsy, as a nurse, your care for this patient, you're going to be assisting this client to roll to their right side. After the procedure, you're going to place a small pillow up under the costal margin. They need to remain in this position for about 8 to 12 hours post-op. You want to do frequent vital signs. You're going to be assessing hemorrhaging on them quite frequently, and you're also going to make sure that they avoid coughing, straining, lifting, strenuous exercise, anything that might aggravate that area and actually cause them to start bleeding. Prior to the actual insertion, you're going to ask them to take a deep breath and hold it, and what that does is it just kind of pushes that liver up against that wall so they're able to get to it easier, the doctor is. Of course, as a nurse, then you're going to take that sliver of that biopsy, you're going to label it, make sure you label it correctly. This is not a test where you can easily go back in and get your sample, so you want to label it. And then we don't shoot it through the tube system, we go ahead and walk it down to lab because, like I said, we can't easily get this back. GI endoscopy, so you can have a colonoscopy, which is going to give you direct visualization down into that lower colon. You're going to go in through the rectum and you'll be able to see that colon. An EGD is just the same thing, endoscopy of course, but it's a esophageal gastroduodenoscopy. So you're going in through the mouth and you're going down and you're able to visualize the esophagus, the stomach, and even part of the small intestine up to the small intestine. Okay, so for nursing, we're going to have dietary fluid restrictions and bowel prep. So this is when they get to do that lovely go lightly, and they will probably be up to the bathroom all night long using it and clearing out their system, right? We don't want any residual left in the bowel, so we want to make sure that's all cleaned out. Go lightly takes care of that. For the EGD, we will give them a spray or a gargle that is a local anesthetic just to kind of numb that area, because they will be swallowing a tube and it can cause some irritation, kind of give them a scratchy throat, which you need to let them know afterwards when they wake up that that is normal. They will be conscious sedated with Versed, so you'll be watching them, you'll be watching their vital signs. And then as soon as they wake up, before they can ever take anything oral, you want to make sure that they have their gag reflex before giving them anything to eat or drink. Okay, so this is kind of what the different scans and the biopsy looks like. You can see here, there's the liver that go in right there, take a small sliver through the needle of the biopsy, send that down to lab. MRI, sometimes people who are claustrophobic don't do well with MRIs. It's really loud, makes lots of noises, and it's more enclosed. Where you see with the CT scan, it's just a circle. You go in real quick. The back side of this is open, and so it's not quite as claustrophobic. And then here's the ERCP or the EGD. You can see they're going in and visualizing the actual valve. Another picture, EGD, basically going in right here, visualizing the stomach. Diagnostic tests, we're going to be looking at labs. We've got our CBC, our RBCs, white blood cells. And with the red blood cells, of course, remember that we are looking to make sure that they're not showing any kind of pernicious anemia. And with pernicious anemia, we know that that B12 factor is created in the gut, and it can lead to anemia. So we're checking out that, checking out white blood cells, make sure that there isn't an infection going on somewhere. Urine analysis, UA, serum bilirubin, cholesterol, lipids, they can show that there's some kind of malabsorption problem there. Serum ammonia levels, checking that liver, making sure that everything is good and fine there. Prothrombin times, amylase, lipase, again, those are your enzymes secreted from the pancreas. And then we can sometimes do a stool analysis as well, which will detect red blood cells, white blood cells, fat, bacteria, or any kind of parasites. Gastric analysis, this is going to be actually analyzing that gastric mucosis, and I haven't seen this test done a lot, but basically it's analyzing the gastric retention and clients with like pyloric or duodenal obstruction. The client will be NPO for 8 to 12 hours prior, and then gastric contents will be aspirated through the NG tube every 15 minutes for 1 hour. pH and cytography will be performed on this. The Helicobacter pylori test, or H. pylori pi test, you'll see this tested. It's kind of easy to do, but it's detecting H. pylori, which is a bacteria associated with peptic ulcers. And so it can be transmitted person to person, oral fecal, or oral. And basically what this bacteria does is that it will bore holes through the mucus lining in the stomach and actually invade it. It causes a lot of damage. It's very, very irritating, very painful, but it allows that stomach acid to penetrate the tissue. So you can imagine how bad that can hurt. All right, that takes care of this section.